I like to talk about the intact orbital surgery. So it's nothing new because the surgery through the orbit, it's very well known, especially in the maxillofacial community, in the ophthalmologic. But the new thing is to use the endoscope through the orbit. So we can approach the lesion inside the orbit and in different way, through the nose or through a superior eyelid approach that is very cosmetic incision. We can deal with a lesion extraconal or intraconal. The decision making is related to the location of the disease regarding the position of the optic nerve. All the lesions that are medial to the optic nerve, we can approach to the endonasal procedure. The lesions that are lateral to the optic nerve, we approach through a superior upper eyelid approach, incision. For the endonasal approach, the extraconal lesion is quite easy to remove. We can approach in a very delicate way, opening ethmoid, removing the papyracea, and removing the lesion, cutting the periorbit, just in front of the lesion, and remove the lesion itself. Much more difficult is the surgery for intraconal lesion, related to the very delicate and important vascular and nervous structures that we have in the orbit. So we have two main windows to enter in the orbit and to deal with this lesion. The easier and the safer is the inferior window, in between the inferior rectus muscle and the middle muscle. We put a stitch around the edge of the middle rectus muscle, cross the septum, and pull on the other nostril. In this way, we make elevation of the muscle itself, and we can work inside the orbit. More often, we do perform surgery to the superior windows. It means between the middle rectus and the superior oblique muscle. In this situation is the tumor itself, usually are hemangioma, are benign tumor, well capsulated. Is the tumor itself that creates the space and push down the middle rectus, and in this case we have to coagulate with bipolar and to resect the anterior ethmoidal artery. In this way we can manage and we can use cotonoid pledget put inside the orbits. In this surgery, the amazing thing is that we always try not to remove the fat. The fat is really important for the orbit. If we preserve the fat, we don't need to make the middle wall orbital reconstruction. And we avoid the enophthalmos, and we have much less rate of diplopia post-op. The orbit is a cone. And if you enlarge the muscle and you put the cotonoid and push cotonoid in the apex of the cone, you make a pull-out of the lesion by itself. So you can remove the lesion with very mild bipolar coagulation of the capsule of the lesion to make hard, and you can remove the lesion without cutting vessel, without cutting nerve, and to preserve the structure inside. When the lesions are on the lateral wall of the optic nerve, we cannot cross the optic nerve, it's too risky to damage. So we make a superior eyelid incision. This incision is very cosmetic. We make incision of the orbicular muscle and nothing happens. We have always to preserve the levator palpebral muscle, but the fibers are differently oriented. The fiber of the orbicular are horizontal. The levator have vertical fiber. So you can recognize, and you go on the lateral edge of the superior lateral edge of the orbit, make an incision of the periosteum, take the plane and make a dissection of all the periorbit. Now, the most important thing is to preserve periorbit, and we use silastic sheet and we use malleable dissector. And if you preserve periorbit and you make a complete dissection of the periorbit inside the orbit, you can see very well the landmark, the anatomical landmark, because periorbit enter in the fissure and in the hole. So you see the inferior orbital fissure, the superior orbital fissure, then the optic nerve, then the posterior ethmoidal artery, and then the anterior ethmoidal artery. And you have a clear vision of where you are. You can orientate yourself simply looking these 5 landmarks that are very important. So you know that you are not rotated, but you are in a correct position. Now, we use the same procedure we have through the nose. So we make incision of the periorbit very close to the lesion to avoid the fat in front of you. And then we use cottonoid to dissect the tissue and to push cottonoid in the apex to make out the lesion. And this is a very, precise surgery, delicate, and the patient have a very, very rare complication like diplopia. We never have bleeding inside the orbit, but if you have some bleeding inside the orbit, you can use the device like flow seal, like Surgiflow, to make a hemostasis of the graft. A different approach is to use the orbit as additional port for the skull-based surgery. And we use the same anatomical landmark, same procedure for approaching the orbit. So superior eyelid incision, very cosmetic. When we are inside the orbit, we know that in between the superior orbital fissure and inferior orbital fissure that are very clear because periorbit goes inside, in between them there is the grit wing of the sphenoid. And removing the grit wing of the sphenoid, we have the access to the middle cranial fossa, to the floor. If we remove the lesser wing of the sphenoid, that is in between the superior orbital fissure and optic nerve, we make a control of the superior portion of the cavernous sinus. So we can have the approach to the middle cranial fossa, floor of the middle cranial fossa, and then lateral wall of the cavernous sinus. That is mandatory for some lesion. And then we can remove the roof of the orbit. And removing the roof of the orbit, we have the anterior cranial fossa. So approach is very important. We use very selected case, but it's very important because give you a secondary approach. So if we have removing a tumor that make an encasement of the optic nerve, through the nose we can make the resection of the tumor. Think about meningioma. You can remove and open and make the compression of the medial wall of the optic nerve. But through the orbit, we can go to the lateral wall of the optic nerve. With this transorbital approach, we have removed a consistent case of sphenoorbital meningioma. Sphenoorbital meningioma are approached with a transcranial approach, with a pterional approach. So this is a very innovative approach. Well, the innovation is the combination of the scope with the traditional approach, but is intact orbit approach. Because in maxillofacial community, for doing this approach, they make orbitotomy. That makes different for the patient, for the morbidity. So I think in selected case can be a very interesting for the future.